sitting in the chair as always. Hi! And guess what? We have a fabulous guest, my sister! The Dr. Amazing. I said the Dr. Amazing. But we have Dr. Kayla Nixon Marshall. Yay!
Hello. Nice to be on the show. Thanks for having me on here, sis.
No, thank you. And so we're talking about health, wellness, and all those things because you are a doctor. I play one on TV. So I self-diagnose all the time.
Yeah.
And I never know what I'm diagnosing myself with. But first, before we hop into, who you are and all those things, we have to toast because we are drinking some amazing rosé from a Black-owned wine company, Sip Suede, Black-owned out of Baltimore. So we're excited about that. So cheers to her. Follow her. I guess we're supposed to say.
Yeah, we should.
So cheers. Okay, so Dr. Kayla Nixon Marshall, what made you become a doctor?
Yeah. Well, I think I always sort of gravitated towards the sciences. So some of it was just like natural, do you like math? Do you like reading? I always really loved the sciences. But I got some pretty early exposure too. My dad is in medicine. He does family medicine. My brother was in and out of hospitals a lot when we were growing up. And so between the two of those, we were just always kind of in hospitals, in different doctors' offices, and then was able to get exposure. I definitely think a lot of our family experiences about when my brother's illness got basically healed and just like how much joy that brought to my family. It was really like impactful how dramatically our lives shifted. So I kind of saw the power of like the medical process pretty early. And then, by God's grace, had some early exposure to like good mentors that looked like me, that were doing what I wanted to do. And then the doors just kind of opened that have ultimately led me to the direction to where I am now.
Wow. Okay, so what type of doctor are you? And like, what was your like sort of like path to get there?
Sure. So I am a minimally invasive gynecologic surgeon. It's a terrible name, honestly.
It is a mouthful.
It's a mouthful, and it doesn't really describe what we do very well, but basically we're like the referral surgeons within OBGYN for complex benign gynecology. So I do a lot of the more severe like fibroids, endometriosis, chronic pelvic pain, adenomyosis, which is another disease that causes a lot of chronic pelvic pain that we're learning a lot more about. So those kind of more surgically focused things that are gynecologic disorders. And really, truly, this is another story for another time, but a lot of gyne surgery training has gone in a direction where there was a need for really much more improvement in just like the quality of that particular type of care for women. And so that's sort of what's led me to this. Like I said, I started off knowing pretty early, since I was 7, that I wanted to be a doctor. So I just kind of did all the, the steps. You go to undergraduate school for 4 years, and you apply to medical school and go to medical school for 4 years, and then you apply to residency, and it's a really crazy process called a match process. The only other similar comparison to what it's like is sorority rush, really. It's like you apply to a bunch of programs, you list them in order, and the programs list in order everybody that they interview, and they match you to one.
Oh, wow.
So then you apply for the match, and I did that, and I went to undergraduate school at Xavier, University of Louisiana. Strong supporter of HBCUs, because that's how I've gotten to where I am. And then I went to the Mayo Clinic for medical school in Minnesota. Met a soror there who was, really instrumental in supporting me while I was there. And then I stayed at Mayo for residency. I did leave for a little while and did a master's in New York. And then I, through residency, really learned all the things about gynecologic surgery that I loved, and that inspired me to apply to the MIGS fellowship. It's called MIGS for short.
Wow. That is a mouthful and a process, and it's a lot to endure. Like, how did you keep your mental health together while going through all of that?
Yeah. That is a great question. I will say not perfectly, you know.
I mean, who can, right?
Yeah. It is a lot. It's a lot of sacrifice to go through. It's a lot of stress, you know, the process that you have to do, just like studying, taking tests over and over again, sometimes failing, sometimes retaking it. And, you know, it's a big sacrifice for, you know, a lofty calling is what I see it. So I am truly, you know, grateful to God that He's kind of helped me along that path. And it really has been my faith that's been a helpful tool for me personally. The community around me, I definitely drew a lot of strength from other people going through the same process, especially other African American people. Like I put in the plug for HBCUs earlier, and truly, you know, a lot of us, you know, went to an HBCU for undergrad and then might have dispersed to more PWIs for medical school, and really needed to rely on each other for support to continue to get through those situations, because it was a pretty big culture shock moving from New Orleans to Rochester, Minnesota.
Yeah, that's a huge difference.
Yeah.
I definitely would say culturally, and like with food and
Oh my gosh, every
just
level.
weather.
Every level. The weather, the size of the city, the diversity of the city, the region of the country, the weather. But I really do think that truly, you know, I took a lot of strength in just the quality of the training that I was getting. You know, it felt worth the sacrifice, truly, because I loved the Mayo Clinic so much. Obviously, it was a huge blessing to be able to be trained at an institution like that. And I really did find the most supportive people. Like, God brought all the people I needed into my life at exactly the right time to help me along the journey. I had people, you know, a lot of my church friends and other friends that, like I said, had come from other HBCUs maybe, or a lot of people that go to the Mayo Clinic especially are from all over the country, from much more diverse places, and aren't necessarily used to small town Midwestern life. So it kind of binds you together. There was actually a group of us that ended up being dubbed the name Melanin at Mayo. Because because we needed the support of one another, and we were all transplants that like came and then left for a different time, but we really helped each other out.
Wow.
Yeah, community. The importance of community was honed into me like never before.
That's so amazing. And like, I mean, I'm from the Midwest, so I get it. But like going to New Orleans, like being from New Orleans and then going to Minnesota, like that is definitely a culture shock, because the weather is definitely.
Yeah. And I actually grew up in Florida too, so you know I was a Southern girl. Through and through. But yeah, I mean, it was a step outside of the box that ultimately really was probably sort of the catalyst for me to be able to do what I'm doing right now.
So you're doing what you're doing right now. What, you know, like doctors have like all those alphabet soup behind their name. Like lawyers were just JDs, right?
Not just.
I mean,
yeah.
Or you might get an LLM or something like that.
Sure.
But like, y'all are like, I can't even make up the letters. Because like my one doctor is like, Dr. blah, blah, blah with this letter acronym and this thing. So what are your alphabet soup, after your name?
Yeah. Well, MD is the first one, so medical doctor. That's what I got at the end of medical school. I mentioned earlier that I went and did a master's degree. It actually is in art history, so
I mean, gotta have balance.
I know, it's an MS technically in art history. I got from the Pratt Institute between my second and third year of medicine, and I did that because I've always been a creative person. I like to paint, and I did a lot of printmaking when I was younger.
Ooh.
And even in college. But then when I got to medical school, Mayo actually does a lot of the humanities in medicine, and there was a big student interest group, a whole center for like the humanities in medicine at Mayo. They have an amazing art collection. If you ever walk through the walls, it's just like an inspiring place to be. Wow. So I got there and I was like, why doesn't every hospital do this? Obviously, funding is probably the big reason.
There's a little bit of an issue with funding.
Yeah. But I just realized I really wanted to dig into like what sort of the built environment of the hospital could do for patients, how it could inspire people, and then all the different factors that go into humanities. They have music, performances, and theater, how that could be infused into medicine. So I sort of rabbit trailed into that for a while, and hope to still do a lot more. There's a lot of a push for in medical education for bringing the humanities into teaching medical students how to be empathetic, how to, you look at a painting and you see lots of little small signs that kind of tells you the story, really similar to when you're meeting with a person that you haven't met before and they have a lot of underlying things that maybe they aren't sharing, maybe they don't feel comfortable, like a way to just like be empathetic, to build trust with patients. I think the humanities, that's one way, but there's so many different ways that there's entire discipline built around basically how to bring those two worlds together. So studied that for 2 years.
so there's that.
Yeah.
So there's that acronym.
Yeah.
Okay.
And then probably the last and most recent one is FACOG, which is it's FACO. FA.
It's alphabet soup. It's alphabet soup. I get it.
Yes. And it stands for a fellow of the Board of American OBGYN, essentially. So,
wow.
So a fellow of the college, the American College of OBGYN. Yes. So that's the last one and the most recent one. applause, because that's huge. Yeah.
Okay, so going into OBGYN, this is like an area I think most people are not, comfortable talking about.
Yeah.
Like,
it's very sensitive.
And it is sensitive.
Mm-hmm.
My mom's on. Hey, Mom.
Hey.
I know we see Z, we see Tara, we see Corey, and Taste Black Spirits, which I am a fan of that. So here we are talking about OBGYN, right? And it's, I think, a taboo topic because people do not know how to talk about it.
Yeah.
And like we're trained as young girls to like not talk about our areas.
Yeah.
So like, our areas, right? Like,
Right,
what I mean?
All the nicknames, pocketbook,
Lady,
and
privacy.
Yeah. Oh my goodness.
So like, how do you, as a OBGYN doctor, like get women or young ladies when they come to your office, when you can tell that they've been trained to be very private about it, to open up? Because it's hard.
It is really hard.
And especially if their mom is in the room.
Right.
Because like that's a whole nother story.
Exactly. So sometimes especially with my adolescent patients, it is important to give them a moment without their parents in the room to just ask if they have anything else that they want to share. Not to make them feel pressured in any sense, but just to kind of provide space for that if there is something that they would rather their parents not know. And I would say a lot of it is just trying to normalize women's health. This is just how God made us. This is how the body is made. Every woman is going through these same things. So a lot of it is, I share that it might be embarrassing, and I always make a point to note that just because I see and do this every single day, so to me, looking at the private parts are looking like an elbow, like looking at an elbow.
It's an elbow.
I always joke with patients about that. So, but I also respect that for them, it's a very personal, private, sensitive topic. So a lot of it is just kind of reassuring and giving affirmation that, you're not the only one that's going through this. You're not the only one that had to make these maybe difficult decisions that feel, this sense of connection. It's just really parroting things that I've heard and learned, from a lot of, people that have done this for a lot longer than me, as well as from the patients that I have had the privilege to work with. And giving a lot of reassurance that basically that we're all in it together, especially as women and as African American women. But I do think a big part of it is just establishing trust and rapport, letting them know that I'm there as an advocate. I think that's a personal thing that I find really important to say, my goal is not to try to push you to do anything that you don't want to do. It's really just to educate you on, why the medical reasons, the physiologic reasons behind what may be going on, and then to empower you to make a decision about what you want to do for your own health. But it's a partnership. We're in it together.
Wow, I've never heard it put like it's a partnership, right? Because like it is it's very uncomfortable. I think most men probably don't know like when women go into their OBGYN, especially at a young age, like how uncomfortable it can be.
Yeah.
Because you're just wondering any and everything.
Yeah.
Like,
yeah.
what do I have? Because, like, you just assume you have something.
Right.
Because you're, like, in the office and, like...
It's just so unknown.
Yeah, and, like, I gotta put my legs in this thing. And I'm like, oh, my God. No one prepares you, right?
Yeah, no.
So what are, like, 3 things you would suggest women in general, regardless of what age group, that they should have a discussion with their OBGYN?
Yeah.
Like, at any age?
Yeah. I would say that's a good question. Let me try to think of the most significant 3. I can think the one that comes to my mind first is just basic anatomy. You know, like a lot of times, like you mentioned already, like these things aren't talked about. You know, some people don't exactly know, you know, what to call it or, you know, how the body works. And so a lot of it is just really describing like what it looks like, you know, and using the accurate terms, and then trying to, you know, if people are coming in with specific complaints, try to explain like, this is what's happening, this is sort of the physiology behind that. But, you know, I would ask about like, you know, when people come in wanting to know like what's going on with my body, a lot of times I explain, well, this is the normal process. And then you probably have this list of things, and these reasons might be why. So some of that is just really like basic anatomy, physiology. So that's one thing the first thing that would come to mind. You know, another thing that I encourage my patients to think about is fertility desires. Obviously, I work in OBGYN, and women's health is for the purpose, you know, that organ system exists for the potential of childbearing.
Yes.
And so I encourage patients to start thinking about, you know, what that might look like for them. Not to push anything on them, but just to say, like, have you thought about, you know, do you want to carry pregnancies, have children in the future, or do you not? And that's okay, you know, if you don't. But
yeah,
just to have that thought process begin earlier, to think about what the reasons might be for why or why not. And then, you know, especially my patients that are, I think it's important to educate women about sort of the natural process of fertility, you know, because I do think
that's real.
Yeah, there's this, especially in our day and age, which I love, as professional women, as women are like growing in the workplace, having more and more professional careers, a lot of us are delaying childbearing. I've never been pregnant before, you know what I mean?
I've never been pregnant before.
yeah, and that's very common experience. So, but it is important to know that, you know, there is still, you know, unfortunately a biological clock, and the closer that we get to the end of the typical reproductive window, you know, the options change and become a lot more limited in some circumstances. And just the risks of pregnancy and things like that go up a lot. So I think it's important to have that discussion, you know, earlier on. I think there's a growing interest in things like fertility preservation, which I always encourage patients to think about doing maybe earlier, just to, you know, recognize that it might have seemed cost prohibitive in certain situations, but maybe it's not, depending on your insurance. So those are conversations I hate when I've encountered patients that are, you know, like between maybe 40 and 45, and they're like, nobody ever told me that this would be harder at this point or something like that. And I, you know, my goal is to at least have heard it before, even if you decide that that's not for you, just to have an opportunity to think about it. And then I would also say, the last one, top 3, I would say the other thing I probably spend a lot of time talking about is management of periods.
Oh my God, like there's not enough trackers in my phone.
Yeah. And there's a lot of things that go into that. There's, you know, structural things that are actually like growing inside the body. There's all these other medical conditions that can cause changes in your bleeding patterns. I think a lot of that includes counseling around hormonal medications, birth control, historically. And I always say to patients, I hate that birth control was ever named birth control.
Because it does so much more.
It does so much more. It's really referring to the entire class of hormonal medication. So, you know, we don't call all, all high blood pressure medicines, water pills, they don't all work that way. It's
true.
just like a different analogy, but to understand that they do so much more than just prevent pregnancy. It really is like how we basically just manipulate hormones in the body to improve symptoms for women. So I think, whatever that looks like for people, managing your periods in a way that makes your quality of life better or tolerable is probably another thing that I encourage people to know. Like, if you have ones that are terrible, don't feel like you have nothing, or there's nothing you can do about it.
Okay, so I think a lot of women have issues about like figuring out when is the time to talk to their doctor about their menstrual, right?
Yeah.
Because it's like we're taught we're supposed to go to work and deal with it, right?
Mm-hmm.
But yeah, we're going there. You're like, I cannot make it through the work day.
Right.
And you're
Right.
like in and out
It's a
of
common experience.
bathrooms, and you're like, oh Jesus, I may not make it.
Yeah, right.
You're having accidents.
Right, and that is embarrassing. It's a
Is
lot.
that the time you should probably start going to talk to your doctor about things, or?
I mean, ideally sooner. I always explain that periods tend to be the worst towards the beginning of the reproductive years and towards the end. So kind of in the middle, sometimes they're a little, maybe it's just the sweet spot. We know how to manage things, but they kind of go haywire when they first start, and then towards the end, nearing menopause, which could be even within a decade of menopause. And the average age of menopause is in the 51, so kind of early. So in
51, y'all, 51.
Yeah,
Okay.
yeah. So, they tend to go a little bit haywire then. And so I think sometimes, patients that are younger, adolescent, might come into the OBGYN, especially if they have really crazy periods. And sometimes I think it can seem as if, they're just put on a medication as a patch over it. So, I think sometimes people are maybe more cautious about starting something that might be a long-term medication at that point, which makes sense. But I would say at least to come in for the educational piece is really important. Like I said, because we've already addressed how some of these conversations aren't happening at home, depending on, at home, at school, wherever. A lot of times there really just might be a big need for education. So I think it's important to at least, talk to and teach young girls about their bodies and let them know what to expect. And then, let them know what's sort of in the normal range. And then if things are really and truly outside of that scope, bring them into the doctor for a conversation.
Okay, that makes total sense. You want to kind of like understand, like, this is okay. This is not okay.
Yeah.
This is where I should probably sound an alarm.
Exactly. And that's something that I, specifically, I don't know. I mean, obviously I'm speaking from my experience as a Black woman. I think culturally for us, where the line is between what we might consider normal and not normal might be different. Some
Right.
other cultures, like a lot of times there's a delay in us entering the
Because
healthcare
we
system.
have a higher tolerance of pain.
Yeah, all those cultural reasons why, and also institutional
Yeah.
reasons why we don't maybe trust the system. You don't see a doctor that looks like you.
Yeah.
You
Trust.
don't know exactly what to expect there, and they might tell you some really horrific things. And like you already mentioned, it's a very private thing to be discussing. And so that's something that I'm really passionate about, is definitely improving representation in medicine. The more that you do see a doctor that looks like you, maybe the more comfortable you are at being really honest and open about what's actually going on with your body. But also just diminishing whatever barriers there are to people that are more, Black women are often more commonly affected by so many gynecologic disorders than other women of other races and ethnicities. And I want us to be able to get in and get our treatment just like everybody else does.
Just treat us like we need to be treated,
Yeah.
Make sure we're not dying, that's all.
Yeah.
We don't want to die, okay?
Right. I don't want us to die.
Yes.
Not at alarmingly higher rates than, everybody else, because clearly that's not. There's so much history and, like I said, so many institutional factors in the way that the medical system runs currently, still, that we have to do a lot of work on. But TBD.
Yes, and we appreciate you for being an advocate and getting into the field to make a change. So thank you for the work you do.
No, it's my privilege. Honestly, I love my job. I really do, and I do it because I see the impact on my sisters, people around me, you know what I mean? And I want healthcare to serve everybody the way that we deserve. So,
okay, well, we wouldn't be the Rose Hour if we didn't. And I mean, people are doing dry January.
Yeah, not us.
Yeah.
Not yet, at least.
Ain't nothing dry but the wine we're gonna try. So want to talk about though, like, how does liquor impact women, whether it's fertility, menstrual, like, what kind of things can people see in their body, and like, are there changes people should think about when it comes to drinking?
Yeah, that's a great question. I mean, truly the only like evidence basis for alcohol impacting women's healthcare is really around pregnancy. You know, during pregnancy, it's not recommended to drink. There is a condition called fetal alcohol syndrome that can be the infants of women that have been drinking during their pregnancies can be affected by, and there's no guaranteed amount of drinking that is known to be associated with it. So that's definitely the one that I would say, the one time in life where it's best to abstain, you know. Otherwise, in general, it's really beyond alcohol. You know, a lot of nutrition and wellness and things, like, there's so many lifestyle factors that can affect patients' symptoms, but none of it is really like a strong, I wouldn't say like a strong like research basis that comes from like academic medicine. Of course, in the wellness world, you know, there's a lot of thought out there, and maybe lesser known studies to, you know, allopathic doctors like myself, but I actually leave a lot of room for certain conditions. So certain things that I see a lot of, like endometriosis, fibroids, adenomyosis, like I mentioned, and pelvic pain, a lot of those are inflammatory conditions. So nutrition actually has a big impact on those sorts of things. I think, you know, sometimes people try like anti-inflammation or anti-inflammatory diets and notice some improvement in that. I always tell patients with fibroids are hormonally stimulated. And it, you know, it depends a lot, you know, our hormones fluctuate throughout so many different phases of our lives. And that isn't in our control, but our diet is in our control. So anything with like added hormones in them, certain plant-based hormones, you know, things that you can avoid there might have an impact and make improve symptoms.
Okay.
And then I do think just being active is actually really helpful. A lot of patients that I see have chronic pelvic pain, and one of the most common sources of pelvic pain is actually all of the muscles like around the uterus and the ovaries and around the
You're not moving
structures. Yeah. So pelvic floor physical therapy is something that I'm always recommending for patients. So just being active and moving your muscles, doing yoga, Pilates, any sort of you know, exercise like that is actually really helpful for that particular condition, chronic pelvic pain as well. So there's a lot in the wellness world that I think offers a lot of benefit, and you know, some might think that there's this, you know, disconnection, I would say, between like medical doctors and people that work in the wellness space. I really describe, you know, medicine and academic medicine specifically as being, the goal of it is really to kind of resolve illness. So if you have a disease, you know, a lot of our treatments focus on improving that disease up into a certain point, but then there's, you know, there's not sick, and then there's like optimally well up here, and then the wellness space kind of fills that gap. So what are ways to really augment your whole being in a sense? And that's different from, you know, not having a disease. There's a lot more that you can do there that maybe we don't study or not taught as well in medical school, but those are still useful things that really should go hand in hand.
I like that you're bringing that up, like the space between you're healthy, but you could be even more healthy.
Yeah.
Like, what can you do to
really well?
Yeah, I like that, and like I don't know. I mean, I could be better.
All of us could probably be better in some ways.
But like I know I'm not healthy, but like I should be. I'm working towards healthy, but I want to be optimally well.
Yeah.
So like, how can I get to that space? I want to get to the next realm.
Yeah. I mean, there's so much, and that's exactly what I mean. Just I think the regular health focused things like monitoring your diet, making sure that you eat like a balanced
I got grapes right here.
things. Yeah, there's some grapes here. Indulging in moderation. What that means for everybody, who knows, but in moderation.
It's between you and your God.
Yeah. And it's never, I'm not a huge fan of like strict cutoff, like you can never have a sweet here and there, never, drink. That's just not my personal MO, but, in moderation, everything's probably fine for the body as much as I can think of. And yeah, I think, again, just being active, being healthy, being like walking as much as you can, even like 30 minutes of walking a day is thought to do a lot for cardiovascular health. And like I said, balancing your diet, avoiding like super simple, complex carbs, not having a diet that's based on all of that, but just as balance.
That makes
That's how I
sense.
describe it.
That makes sense. And you don't want to be in one of those ambulances that just went by. So, makes perfect sense.
Yeah.
Okay, Kayla, I know that we are starting late and we're enjoying this wine, and you're giving us mad tips and a lot of great information. But I want to end with one last question.
Yeah.
If you could have chose another profession outside of being a doctor, what would it have been?
Yeah.
I kind of think I know because you kind of alluded to it, but like, what would it have been?
I mean, that's a hard question because even if I didn't get paid to do what I do, part of me feels like I would still be involved in healthcare in some sense. And it is because truly I love it. I see it as a calling. So, that's what I'm gifted for. But if I could maybe add something else, maybe I'll change it
a little topper.
A little topper. Yeah, I mean, I did already mention I love the arts and humanities. I love teaching and education too. So maybe something that tied the two of those. I used to think of, I already mentioned that I like to paint a lot, and primarily now I do mostly like surgery and surgical gynecology, so I feel like that's like my creative outlet now. I like it to use my hands in that way. But if I didn't do that on a regular basis, I probably would be more involved in the arts. And similar to one way to maybe tie it all together, I do feel like the arts have a way of sort of tapping into a wellness, so to speak, that is a little bit more spiritual, a little more transcendental than the physical body. And so that's a way that I like to maintain balance.
I love it. I love it. Dr. Kayla Nixon Marshall, if you will, my sister from another mister. Wait, you keep the same outfits on. I'm trying to see what I'm gonna wear. Dr. Ponder. I don't. Okay. We have another doctor in the chat. Hey, Dr. Neosha Ponder. But okay, I don't know what that means. But Kayla, thank you so much for joining us today. Do you have any last words for everybody?
No, I would just say thank you for having me, of course, sis. And I'm glad to have had the opportunity to talk about women's health, something I'm very passionate about. And if nothing else, I would just encourage everybody out there that maybe has questions about their bodies to talk to your doctor. Maybe find a doctor that you trust at the outset, and once you have that relationship. And if you don't trust the doctor that you currently have, switch. There's no harm in finding one that actually that you relate to. A lot of times I actually love when my patients come in with a list of questions for me, like why should I trust the information that you're giving me? So have zero hesitation about switching if something is off. But yeah, I would just say, don't hesitate to voice anything that's actually bothering you, and to just advocate for yourself and your health.
Well, thank you again.
Thank you.
We're going to finish this amazing Sip Suede black-owned wine from our girl Kira out of Baltimore, out of B-More. And we thank you all. We're going to go back to our regular scheduled program on Rose Hours on